Welcome to Value-Based Care Insights, brought to you by Lumina Health Partners, a national healthcare consulting firm focused on improving the strategic, financial, and operational performance of provider organizations. On this program, we will explore trends and share valuable insights on how health systems and medical groups can optimize their performance to meet the demands of this increasingly complex healthcare environment and shift to transform the delivery of care. Value-Based Care Insights is hosted by Daniel Marino, Managing Partner of Lumina Health Partners. Daniel has been in the industry for over 3 decades and specializes in shaping strategic initiatives for organizations in areas such as population health, clinical integration, physician alignment, information technology, and data analytics. For additional insights, visit luminahp.com and sign up for our newsletter. Dan, over to you.
Welcome to Value-Based Care Insights. I am your host, Daniel Marino. Well, we're continuing our series on looking at different specialty service lines. And I'm excited today to have a conversation around emergency medicine, and in particular, kind of diving into some of the challenges that hospitals are having with their emergency departments and just, all the things related to serving the community and just managing through some of those challenges. So, what are some of the things that hospitals have been struggling with? Well, I think the big one is overcrowding. In most, if not all, emergency rooms, emergency departments, they are faced with overcrowding, patients having long wait times, and and I see it only getting worse, especially with the challenges that we have with primary care shortage and patients not being able to get into to see their physicians. And if they need care, they're going to go somewhere. They're either going to go to urgent care, or if urgent care is closed, they're going to go to the emergency department. So again, the whole notion of overcrowding certainly challenges the whole healthcare system. But as well as then the overcrowding, what we see is a lot of the strain that is being placed on the emergency medicine providers, the physicians, the nursing staff, the clerical and administrative staff. That strain, again, it's a high pressured area. And again, the strain really does have impacts in terms of the care that we're providing and just really serving the needs of our patients. But emergency departments are so critical in serving the community, as well as then obviously supporting the hospital and the margin. So to walk through some of these challenges, I'm really excited today to have with us Dr. Richard Wolfe. Dr. Wolfe is Chief of Emergency Medicine at Beth Israel Deaconess Medical Center. It's a nationally recognized leader in emergency medicine. Dr. Wolfe has spent quite a bit of time not only supporting emergency medicine, but really acting as a national leader, putting in different models and so forth. Dr. Wolfe, welcome to the program.
Thank you, and thank you for the invitation. There's nothing I like better than talking about the problem I've been wrestling with for the last 25 years.
And it is a big problem at that, no doubt. So maybe we could start here. When you think about some of the challenges that we're facing as an industry with emergency medicine and the emergency department, what are the top things that come to mind?
Well, you began with the problem of crowding, which gets down to the essential problem for the hospital, because on a day-by-day basis, what you see are angry patients and families, errors being made, and problems ultimately that can be quite costly as well to the bottom line, as well as damaging to the image. So there's clearly people feel the problem at the level of hospital administration and on the front line in the emergency department. The problem is there are no really good guardrails, and what I've seen is a slow progression where this thing, the resource gap, which is what it is, to deliver emergency care continues to widen because of economic pressures.
Yeah, absolutely. And So what I've seen and what we've done with a lot of hospitals is we begin to think about that and supporting emergency medicine. The immediate care urgent care strategy is one that's really been taken off, right? And it's many hospitals have started to incorporate those strategies as a way of being able to provide additional support to patients, both in overcoming some of the patient access issues that we've been having, but also, patients who are, let's say, low risk or don't necessarily need to go to the emergency room have another alternative. But I don't know if it's actually working because we're still continuing to see the overcrowding in the emergency room.
So it really breaks down. There are three problems, right? Input, which is where will patients go? And if you can get them to go somewhere else, that would help. The throughput, and then the output, how do you get them once their emergency department stay is finished to the next stage of the care? So urgent care is part of the input solution. Can we divert patients elsewhere? That's always been the rationale for urgent care. The problem is there are very different types of urgent care based on how you staff them, what resources you place. And the vast majority staff with mid levels without really high end imaging or a full scope of labs ends up competing and diverting more from the primary care office than they do from the
Yeah.
emergency department. In fact, they tend to refer to the emergency department. We've experimented here in Massachusetts with urgent care staffed with emergency physicians, CT scan imaging, full scope of labs. And we've actually shown that those do divert from the emergency department and they get only not low acuity, but actually occasionally mid-level acuity where you're trying to determine do they need a hospital admission. So it can work, but it has to be designed carefully. And unfortunately, so far, there's not a lot of evidence telling people how to do that.
No, and you bring up a good point. Most of the urgent care that we're seeing right now it is diverting more so from primary care offices and not really not solving the problem of overcrowding in the emergency departments. That there's no doubt about that. Um, but the strain, I think, is another large issue. The strain that is being placed on emergency medicine physicians in particular. And, I think if you're an inner city emergency department, even versus a rural, that strain is the same. You're seeing a lot of pressures because, you have to support those emergency rooms 24/7. What are you seeing in terms of the challenges for a lot of your colleagues?
Well, the so as you said, we've been a little bit victims of our own success in that we've defined ourselves capable of handling anything at any time at any place. So what's happened though is as the workload has exceeded the resources available, the emergency providers find themselves very often with moral challenges, having to ration care because you don't have everything that it takes, and having to make choices that are extremely unpleasant and against their very ethical code. Um, Secondly, it's that effect is not simply at the level of the emergency department, it spills over to all the services that support it. For example, CT scans get overwhelmed, so there can be hours of wait, which hits that second area, the throughput time,
Yeah.
and actually ends up making it very difficult to recruit technicians for CT scanners and really has had effects on, say, radiologists. The same thing, the services that catch the emergency patients on the inpatient unit at the hospitalist, which now have to actually provide inpatient care, often in a hallway in the emergency department, have also been adversely affected in terms of morale and in terms of seeing their ability to deliver the role the way they perceive it should be done.
So are you seeing, because obviously there's a shortage of providers all over, and I think even in emergency medicine, you don't see as many providers, I think, as we certainly would need given the amount of schedules and everything else. Are you seeing the compensation and as well as then the reimbursement keeping up with the economic challenges of a lot of in support of the emergency departments?
Yeah, so I think for now, it's held well. In fact, the one type of provider I haven't had trouble staffing in my departments, or most people haven't, have been actually the emergency physicians. If you're
Hmm.
able to create an environment, it's nursing techs, literally all the other providers, because after the pandemic, about 20% never showed back to
Right.
work.
Yeah. 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 We
And
had a
so that's
big, obviously in the pandemic, a lot of our provider colleagues left the industry, right, with early retirement. And you probably saw that a lot with nursing and some of the other clinical support personnel, I imagine.
Yes, no, no, and that's still true to this day. The cost of nursing, for example, has skyrocketed because of the shortage. And yet we still struggle occasionally to staff the department. Plus, the people we're getting often are recent grads out of nursing school, so don't have the experience and skill sets of the senior nursing staff we had pre-pandemic, which were able to carry higher loads, and actually were less likely to make, the early errors you see in emergency care.
For, for some of the emergency departments and some of the hospitals, they're directly employing some of the emergency physicians and so forth. Others, they contract with them. What are you seeing in terms of the trend of contracting with external emergency medicine groups? Are they able to fund themselves, or are you seeing subsidies, stipends, and so forth becoming more and more part of the financial arrangement with the hospitals?
So corporate medicine was making emergency medicine profitable through out-of-network billing
Hmm.
without contracts. The no surprise billing laws really stopped that and
Yeah, it changed a
made
lot of that.
other types other types of practices are more competitive. Most emergency departments require fairly hefty subsidization from the hospitals on hospital employment or even occasionally corporate medicine. There is a way to do it if you create practices that are very transparent and give the emergency physician some degree of ownership. They tend then to actually increase their, the good marker of productivity would be RVU per hour. Once they feel that that workload is aligned with their mission and income. But if they feel those two things are cut off, then they'll tend to focus on, detailed oriented patient care and not really worrying much about, the throughput issues.
If you're just tuning in, I'm Daniel Marino, and you're listening to Value Based Care Insights. I'm here today talking to Dr. Richard Wolfe. Dr. Wolfe is the Chief of Emergency Medicine at Beth Israel Deaconess Medical Center, and we are talking about nationally the challenges that are placed on emergency medicine and in particular emergency departments. Dr. Wolfe, I want to kind of shift our conversation to what you're seeing with potentially some solutions or some new innovative approaches related to supporting emergency medicine in hospitals. As I think about it, it's emergency medicine is so critical in supporting communities. It's really, in most cases, the mission of why hospitals are there, right? It's the beginning part of the mission. You have to be able to support patients in the community. But I also feel like if done well, it can support the economics of the hospital. It can support market share. If there's a real focus strategy around growth and how you want to begin to really support emergency medicine and all of those things within the department. But it doesn't come without at least being able to incorporate some innovative solutions. What are some of the solutions that you're seeing or the new models that you're seeing that hospitals are starting to undertake as they're thinking about maybe reinventing or maybe a challenge, working through some of these challenges in the emergency department?
Well, there's some oldies but goodies that people haven't really universally implemented. The most classic one is the concept of surgical leveling, that our hospitals function on the elective basis, the patients you want, on a 5-day week, where weekends are really very low in terms of use, and hospital capacity actually is quite ample. And that if you could actually get the ORs to function and surgery to be done on Saturday and Sunday and to use the full 7-day cycle, you can have remarkable decompression. That was shown in studies by Gene Litvak, initially at
Mhm.
Boston Medical Center. It's been done in a number of places and has had very positive effects in terms of decompressing crowding and also increasing hospital productivity. But curiously, it's still only implemented on my last check in about 6% of hospitals because it's hard to get OR teams to be willing to work on weekends. Our
Yeah.
culture doesn't like it. But it's been one very win-win solution when you can get it. Um, Lean process has been talked about a lot, but often doesn't get applied to the emergency department throughput. And it's mainly about putting measures, accountability, benchmarking into the two components that really drive up emergency department length of stay, notably turnaround time of imaging of testing, labs, and particularly complex imaging, CTs and MRIs. And then secondly, turnaround time of consultation,
Yeah.
because rely on other specialties for a number of problems, particularly that require admission or procedural intervention.
Right. Well,
Um,
having the consults there, having the surgical consults or the other specialty consults available to come in. I mean, that's a big area of delay oftentimes in a lot of emergency departments.
right. To come in and then to understand that they're on the clock and that they have to reach decisions promptly so you can keep the flow going.
Yeah. One of the areas that hospitals, it's really gained more and more attention over the last couple of years, obviously, is the inpatient stays, right? And the length of stays. And it's sort of a double-edged sword because a lot of emergency departments, when patients come in some cases, they have to be admitted. In other cases, depending upon when they were discharged, if they fall within the 30-day readmission, you need to kind of focus that. And then probably third to that is in some hospitals, they may not have beds available. How are you seeing observation units and say alternative pathways for these patients? Are you seeing any solutions there that hospitals are starting to undertake to kind of balance the inpatient mission versus the patient coming in and just sitting in the emergency room, that throughput?
Yeah, in other words, that is in some ways a way to divert the input to the inpatient unit. It's very effective. You can actually allow the emergency physicians to select out patients that say have only a 15-20% need for an inpatient admission after 48 hours and put them in an observation category. Those are the patients that if you admit them to the floor, you're going to be billing as an observation anyway, but in very
Right.
expensive, well-staffed space. And in an observation phase, particularly attached to the emergency department and supervised by the emergency physicians, you actually shorten, it's been shown that it shortened lengths of stay. You don't need the same, concentration of nurses or the same level and cost of space. So it's one, very cost effective. Two, the emergency physicians actually can be paid for the clinical work, so you don't need to actually support hospitalists or others to provide that care. So it ends up absolutely being a win-win solution as well.
Yeah, I agree
And
with you, and I'm glad you kind of described it that way. We've had the opportunity to work with a few different hospitals, and I'll tell you, it really comes down to the data, right? Understanding the patients, understanding where they've come from as they present to the emergency department, and then as you start to dive into the patient's condition, I think accurately identifying the patient's risk. So you're able to really drive that care to the patient that, based on what their need is, right? So you then begin to understand, is it more of an observational based, or do they have to be admitted? And then, you're kind of managing it. And it's really moving into that proactive approach on managing the patients. Are you seeing a lot of emergency departments, emergency medicine physicians, are they starting to incorporate a lot of the patient outcome data as a mechanism or as a support component of driving a lot of the care plans?
Well, they certainly do track outcome for a number of features. I don't know how many have leveraged that, and they do obviously track the number of observation patients that end up on inpatient units. I don't know how many have translated that into creating the solution of an observation unit. Interestingly, having personally run observation units for a very long time, the one remarkable feature is if you tell an emergency physician, I only want you to put a patient in here if you think there's less than a 15% chance they'll need to be admitted,
Hmm.
and they will nail it right on the head without any
Really?
other directive or instruction every time
Yeah,
when you
that's
actually,
interesting.
uh,
Yeah.
you know, the issue is they've been tracking and they build up pattern recognition for their patients, and they have a good gauge of who really is going to kind of stay upstairs for many days and who might be able to be turned around in a short period of time.
Right, right. So when you're talking to some of your colleagues around the country and they're coming to you with these challenges of overcrowding and maybe the pressures that they're being placed with maybe not having enough inpatient beds and so forth, what do you feel like is kind of that sustainable emergency medicine model? I know it's kind of very broad question, but where do you see are the high impact points of change?
So I'd like to frame that in what I think is coming, which is with the changes in healthcare, the defunding potentially of Medicaid, the shift from commercial to government payer. Reimbursement for emergency care based on professional fees is going to get harder and harder. And at the same time, the work environment will get more and more difficult. So it's a key, I'm framing this as a key question because how are you going to keep them on the farm when it
Yeah.
really gets so toxic they can do something else? Uh, I would say that the concept of transparency is key. It's getting the physicians themselves involved in the decision making, helping them understand what economic forces are driving it, why the hospitals can't just open other beds to solve the problem, why putting patients upstairs in hallways may decompress the emergency department, but creates its own set of problems. So the more you make the physicians partners in the process rather than employees and victims in some ways of the process, the more you're going to be able to retain and the more you're actually going to come up with innovative solutions to be able to fix the problem.
Well,
But
and I think that's such an important point. You have to bring physicians, emergency medicine physicians into the fold and having those conversations. I really feel like we're going to be faced with just continued challenges, if not more challenges, within the emergency rooms. Many folks believe, and I'm one of them, that over the next few years, if the one big beautiful bill continues to take shape, you're going to see a lot more patients, a lot more of our healthcare consumers losing coverage, right? But the care needs don't go away. They still have to get care. So where are they going to get care? They're going to go to the emergency room. So I don't see the issues of overcrowding reducing. Frankly, I think you're only going to see it increasing, especially if patients do lose coverage. So I think your point is well taken. You have to engage the physicians, but I also feel like we have to put in new innovative care models, new pathways in order to manage the patients. We have to find a way to get out in front of it. Otherwise, we're going to continue to be faced with these issues time and time again.
I I agree completely. I mean, I do think the ultimate answer is we are going to need some type of healthcare reform to align the finances with the needs of the population. That said, there's still a lot of ways we can reduce the burden, try to close that resource gap by innovative uses of space. Certainly, telemedicine as a way to sort of divert patients potentially from the emergency department, observation units, as you suggested, and then looking at the flow on the inpatient unit because emergency crowding is really hospital crowding
Hmm.
and things like discharge units, care plans, better discharge planning so that people get out on time rather than have to have another day in the hospital because of disorganization. There are a host of small little pieces that are discovered just through lean processes that
Sure.
can actually have a major impact.
Yeah. Well, Dr. Wolf, this has been great. I really appreciate it. You bring a lot of great insight to obviously our conversation and some of the challenges. If any of our listeners today, and we have many providers, many administrators and physicians who tune in from time to time, if they're challenged within their own organization, facing with many of the things that we've talked about today, any recommendation as to where they should start? What should they really think about as a starting point to maybe help to think about delivering care differently in their own emergency room?
I think if they're ready for it, to sit down with the emergency physicians and have an open, frank discussion and sort of hear where the pain points are, where the problems are, and do the same sort of with the different pieces of that sort of flow, hospitalists, radiologists, technicians, and so on, to really make sure you understand the elephant, so to speak, so that you can then begin to try and really address the core sort of dysfunctions and workarounds while coming up with some innovative solutions that others have tried.
Yeah, I agree, and that's a great point. As we've said, I think to collaborate with your emergency medicine physicians and to think about the new innovative approaches. I mean, they're seeing it day in and day out, right? They're the ones that are going to be able to really come up with the ideas and the solutions to drive it forward. Well,
Exactly.
Dr. Wolf, thanks again for coming on. Great discussion. I have a feeling this won't be the last time we're going to be talking about this. And again, I wish you a lot of success. You've done some phenomenal things in your own organization and truly a leader as we're being able to re-innovate and restructure a lot of emergency medicine, emergency care that's being delivered at the hospitals. So thanks again for your time today. This has been great.
Well, thanks for the invite, and I really did enjoy the discussion. Thank you.
And if you're tuning in and interested in hearing about this topic or other topics we may be talking about on Value-Based Care Insights, please reach out to me at dmarino@luminahp.com. You also can visit our website at luminahp.com. I want to thank everyone for listening and tuning in. Until our next insight, I am Daniel Marino, bringing you 30 minutes of value to your day. Take care.
Are you at a crossroad with value-based care? Do you need to chart a future strategy or improve your organizational performance? Visit us at luminahp.com to learn more about our consulting services and leadership development programs. Also, you can sign up for our newsletter on our website and follow us on Twitter and LinkedIn. For more information about value-based care insights, visit the programs page on healthcareradionow.com or luminahp.com. Join the conversation using our hashtag VBC Insights. We are Lumina Health Partners. Thank you for joining us today. Until the next value-based care insight, stay well.